there are different indications to do in calcaneus osteotomy. It depends on the pathology you have. Sometimes you have a pes plana valgus with a hindfoot valgus pathology where you would like to achieve a varus correction, or you have a hindfoot varus where you would like to have more valgus positioning of the calcaneus. Also, there is the indication for a Zedek osteotomy where we would like to tilting the posterior part of the calcaneus to anterior to reduce the tension of the Achilles tendon. All those operations are technically possible in a MIS technique. For this, I will show you the position of the osteotomy. It's a lateral approach. You see here the calcaneus. I draw the CC joint and the subtalar joint, and the osteotomy, the starting point for the osteotomy is about here. The sural nerve is about 1.5 centimeter distal to the tip of the fibula, so we are right away from there, and we are avoiding incision by doing this in minimal invasive technique. This is the drawing, and you can check the position of the osteotomy with the lateral X-ray. That would be a good position to start the osteotomy. The goal is to exit plantar a little bit in front of the position of the plantar fascia and dorsal in front of the Achilles tendon. The osteotomy could run in different directions. There's the chance to do it in a chevron shape, which gives you more stability, but it's also to avoid a dorsal or plantar malpositioning. But usually I do it in a plain cut, so this is also possible. Same technique. First you start with your incision, longitudinal incision, and then you drill into the bone and work from inside to outside. So you drill into the calcaneus bone and you tilt your burr to proximal and then to lateral. This burr is a 30 millimeter long and 3 millimeter in diameter. This helps you to get a good shifting because you reduce a little bit bone, a little bit shortening. That helps you to do a medial or lateral directed correction. If you bring in your burr, you have also the chance to tilt towards distal or proximal. I try to avoid tilting to dorsal because by that I get some kind of lengthening, and this will disturb my potential of correction. So a little bit shortening by using the 3 millimeter burr and a little bit tilting towards distal medial if you would like to do a varus positioning of the metatarsal. So bring in the burr, check the position with a good lateral view, and then starting with the burr. You go in. The calcaneus bone is usually 3.5 centimeter in the diameter. So first of all, I start with the medial border. I go like this, and then as soon as you lose the bone contact, you stop. Then you go back in and do the same towards plantar. Then you finally cut the whole area from medial to medial. And then you go further in and do the same procedure with the lateral cortex. Same technique again. Going plantar. As soon as you stop, if you lose the bone contact, you are not in trouble to hit the medial vessel or nerve. Then you can shift the calcaneus in the desired position. As soon as you have shifted it, I use a clamp, bring it in. Then I have my correction. You see it here, the tilting. You can add on some kind of rotation if you would like, and shift it and check the correction. Now, the osteotomy runs this way, but by tilting it and shifting, we have already a stable position. What I like is I don't have a dorsal or plantar shifting in those cases. And now it's quite easy. The next step, like in an open surgery, you have to fix it. Just bring the key wire in and fix it. Be aware by shifting, don't try to be in the mid portion. You're running maybe medial out, a little bit more lateral. So this is my first screw, and then there comes the second one. So I have compression and rotational stability. The second screw is a little bit more proximal. And try to be parallel to the first one. So this is done. You have 2 incisions for the screws, 1 incision for the osteotomy. Now I can bring in 2 screws, headless screws. I use headless screws because there's no prominence in the calcaneus in that area. I use 5.5 screws. You can use definitely larger screws if you would like, but by that you have a stable positioning and correction of the screws and the osteotomy.